I'm very glad tonight to have our speaker, Mark Berg. As you know, this health care bill that has been passed has lots of controversy with it. I tried to read some of it and was lost. I think that Greta Thunberg on the other night had said that she had tried to read it, and she's a lawyer, and could make neither head nor tails of it. And Mark has studied it pretty well. This is Dr. Mark Berg, who got his degree in Syracuse, New York, and his family practice board certification in 1987. Now, Mark practiced emergency medicine for 13 years and family primary care for 7 years. And I think he just joined us down here a couple of years ago. He's been giving presentations on ObamaCare and various other healthcare issues, including the comparative effectiveness research. And I feel really lucky to have him here to speak on it. I think Mark has read the bill a couple of times, and I am going to give the floor over to him to inform us of what he has found.
Hello, everyone. I have just a couple of questions at first. Who's not been to a Tea Party meeting before? Good, a lot. Well, welcome. And are there any physicians or physician assistants in the audience? Good, I can say anything I want. Just kidding. Against them. All right, what I want to do, I'm talking about mainly about the ObamaCare bill. I'll call it the ObamaCare bill, even though people say that's a slander on it. But it's known by that mostly, and if you're proud of the bill, I don't think you should worry about what it's called. It's the Patient Protection and Affordable Care Act. If you look it up, in the last several months, it's been mostly referred to as the ACA, because conveniently, people referring to it have dropped the patient protection part of the PPACA, which I find interesting. What I'm going to do tonight is a little bit different than probably what you've seen before as a presentation for a healthcare bill. I'm not going to be talking anything about tax issues or money, except if you have questions about it. I'm good with numbers, but I don't think it's the most important thing. The other problems with the bill are going to stick with you and going to get under your skin for the next 20 or 30 years, a lot more than any financial situation will. So what I'm going to try to do is I'm going to try to paint a picture of what this bill is as a reflection of the landscape under ObamaCare. And unfortunately, if I do a good job of that, it's a pretty grim picture. But I do have some things to tell you that you might be able to do to help remedy this situation, and I think we need to do. Okay, first thing I want to start out with asking kind of a rhetorical question is, what is health care and how do you get health care? In other words, when you go to the doctor or to emergency room, but particularly a family doctor or a specialist, and you're in his office, what is the history behind everything that allows you to get that care? Certainly if you were in Ethiopia, you wouldn't get that care. It's not the fact that you'll get that care because it's 2011. So think about the reasons you get that care. And my talk is going to be related to that. All these things are pretty much what goes on in order before you can make any decision on your own health care. There's been research in the past, thousands of years ago, into looking what a disease was, and since then it's gotten very technical, finding cures. And then there's been information dissemination. You have to get the message out, obviously, which is what the Tea Party has to do. It'll go to researchers, specialists, and finally the local docs in varying degrees of time, and they'll decide if they even want to incorporate that in there. They could have read other things in other sources and decided that what they're reading by your research isn't very good. So he'll decide that, he'll decide to incorporate it in his practice, and then he'll explain that to you. You'll have read things on the internet, you've made some effort to be knowledgeable about it, you have had problems in the past and family members, so you and your doc will talk about it, and then you're going to decide if you think it's worthwhile for you, if it's going to be efficacious enough, if it's going to help you in a reasonable length of time, and then you're going to consider costs. But it's funny because you're really not going to consider cost until you've decided to do it. The government kind of does it the opposite way. Okay. Well, what are the goals of Obamacare? I have found these things in the bill in various areas, and I have something coming up that's a little more specific, but it's supposed to do this, and it sounds pretty good. It's going to reduce variations in delivery of health care and develop best practices, and everybody likes best practices because they're the best. And it's going to expand health information technology, detect and monitor trends in health disparities. Sounds good. If there's problems, you need to find out about them. Going to reduce the per capita rate of growth in Medicare spending. This is what you hear a lot about, and I'm not going to talk a lot about the specifics of spending. Protect and improve Medicare beneficiaries' access to necessary and evidence-based services. Well, it's interesting because when you read these things as I just spoke it, you go, well, we're going to do this and this and this. But what you're going to do is decide about beneficiaries getting access to necessary and evidence-based services. So the question that comes to mind before I finish a sentence like that is, who's going to decide what's necessary and what's evidence-based? If you don't know that, you need to pay attention. Okay, well, what's the big deal? Consider these two sections alone in Obamacare, and I pulled out some of the things that will make a point. National strategy, and that's exactly that, a national strategy that they want to convey on everybody. And establishment of a Center for Medicare and Medicaid Innovation within CMS, the Center for Medicare and Medicaid Services. Okay. And here it is. National priorities are going to do this. This is what the bill says, and this is what someone could tell you, and it sounds good. Address gaps in a comparative effectiveness information and data aggregation techniques. The problem is, although we all like to address gaps, I mean, I was in construction, and a gap is a bad thing. You've got to patch over a gap. So we'll do that. But you're going to address gaps in comparative effectiveness and data aggregation. Now, a lot of you are pretty sophisticated, and you know what comparisons are, and you know what data is, and aggregation is putting it all together. That doesn't tell you how they're going to do it or exactly what they're going to do. So if you say addressing gaps is good and you think addressing data aggregation their way is good, you may not be right. It's going to enhance the use of healthcare data. You know, first thing I read this, I say, well, use by whom? I'll bet all you people, as soon as you read that, thought, well, you know, your doctor. Well, maybe. But I can tell you right now, the doctor is not 5% of that use of that healthcare information. Improve research and dissemination of strategies and best practices. Well, that's interesting too, because improve research. I checked to make sure I wasn't reading it wrong. It's not research about best practices, it's improve research. Research has been going on for hundreds of years. Researchers do research. I'm not a researcher. But someone in the government that wrote this bill thinks they know how to improve the method of doing research. It's not to do with healthcare, it's about research. And you'll see why. The national strategy shall include provisions for addressing coordination among agencies within the department. And now again, it's funny because it's the way the picture is painted. Coordination is good. We all know that because incoordination is bad. If you're incoordinated, you're incoordinated. So we want coordination within the department. Does anybody have a good feel for what that means? Some of you can suspect, but I'll fill in the details. Okay, Center for Medicaid and Medicaid Service Innovation within the Medicaid and Medicare service. They're going to test payment service delivery models that will transition primary care practices away from fee-for-service based and reimbursement and towards comprehensive payment or salary-based payment. Yeah. Salary? Exactly. Salary-based payment means I, as a physician, am employed. In fact, salary is used more for professionals in a sense, actually, and wages for other people that get a bill. So technically, they're spot on. They're going to make professionals, doctors, and everybody else be employees. But they don't say who employees from about who. But that's what a salary position is, an employee. And risk-based comprehensive payment. Does anybody have an idea what that is? I don't know. I kind of know what they're talking about because I know the flavor of the bill. but not because of those three words put together. No, it's not really straightforward. They put that in there so you gloss over, so you read the good parts of the sentences and you think, well, whatever, I don't know what that means. It sounds good though. So, okay. Now they're going to vary payment to physicians according to their adherence to appropriateness criteria. Well, first of all, isn't that kind of heavy-handed to tell your doctor what to do? But the real question is, and why I highlighted it, is again, who decides what's appropriate? You and your doctor, your doctor, both, or the government. Utilize medication management therapy. I'll get into this later. You'll never get what that is unless you read the bill. Pay providers for using decision support tools. This I find rather offensive being a doctor, because you're going to pay me for using decision support tools, whatever they are, but and to pay me to do something that you want. And they're going to pay me good, although it's only going to be 2%, for example, for a year, and then 1%. And if I don't comply after that, it will actually be a loss of 1% and then a loss of 2%, like they did with mandated electronic health records and electronic prescribing. So that if you don't do it, you don't even get paid the normal fee for Medicare. Most people didn't know that. But they're going to pay you for this to get you hooked on it, yet they complain and make a big stink of me getting a pen or a travel mug from a drug representative when they come and educate me on something. I didn't like drug reps in my office very much, so I kind of kept them in line. But they were usually the ones that could answer questions that I had about new drugs. And it influenced me to the extent that if you do a study and find out doctors are using those drugs more, that may be true, but that's because those drugs are better, for example. I certainly didn't use new drugs just to use them. I used generics frequently. Okay, to identify areas for research, an independent medical board will advise the secretary on research priorities. It really goes back to the very beginning. Not only are they going to have some kind of research, they're going to look into what they want to research. In other words, they're going to have an agenda, and you'll see this. I'll tell you up front so you can look through the details. But there'll be an agenda, for example, by the HHS secretary to prove something. So she'll find out what kind of research they can do, fund it, and then they've got their answer, which they'll conveniently convey to you. Now, develop topics for recommendations, recommend areas that deserve further review. This is the United States Preventive Services Task Force. This has been there before. A lot of what I talk about, most of it's new, but this has been there for a long time. The Preventive Health Services Task Force. And it does this kind of thing. But I want you to keep an eye out in the general flavor, the general picture that I'm painting, how they're using this agency. Okay? If it's a little fuzzy, I'll fill in the details for you if you have questions. Which reminds me, if you do have questions, I'm going to stop before the end of the talk, probably in the next 15 minutes if I can speed up, so that you can guide me on what is not clear, because I want to finish off with some of the impacts on doctors and physicians and a little bit more about the comparative effectiveness research, and I want to make sure things I've already discussed are clear. And then I'll take questions off the floor later, too. It's not that I want to ignore anybody. I'm scared. Anyway, they have an interagency pain research coordinating committee. That's also going to develop a summary of advances in pain care research that's by federal agencies. They're actually going to do that pretty much to toot their own horn that they've figured out something they wanted to figure out. Identify critical gaps in research on the symptoms and causes of pain. Well, this I find interesting, because you have these people writing something like that, and they're so smart they can write a bill, and they can tell healthcare professionals, the insurance company, people making drugs, how to do their job, because they know better. But they can't seem to understand that pain is a symptom, and you don't have a symptom of a symptom. What is a symptom of pain? Pain's a symptom. A sign is if I see you and you have a pustule, that's a sign, I see it. If you have pain, you have to tell me it's a symptom. There are no symptoms of symptoms. Okay, Secretary shall convene a conference on pain to evaluate the adequacy of pain management in racial, ethnic, gender, age, and demographic groups. I put that in there because it will come up, not because I'm singling it out, but this is in this bill no less than 50 times that I could have put in here.
Women and minorities,
Everybody.
hard to hit.
Everybody. So you keep an eye on that, even when it's not been in there, because that is one of the agendas of the administration, as you know. They want to make everything equal. We're not talking about just health care. So if you could possibly identify somebody that you think is inadequately served in any respect, you have to do something about it. And interesting, you know what you're going to do first? What do you do always first? What do you start with? Research. You're going to do research to prove your point. You're going to go out and fund research that shows that there's disparities. And you'll find them that way, overwhelmingly. Comparative effectiveness research, I'll save that till later. I have a handout on it that's very good, and I'll take questions because you'll have questions, and I'll take questions from the floor on it too. But that's a longer subject. Okay, education is the next thing you have to do, dissemination of information. That word dissemination of information, those words, is in the bill all over the place. What's the best way to get information in the hands of all the stakeholders? That's what they call them. You are a stakeholder. I call you patients or citizens or friends or whatever. You set up a program for the purpose of testing, scaling, and disseminating of interviews. In other words, you research how you are going to get the message out to the people. Yeah, you research how you're going to get the message out to make sure you can get the propaganda, the message out correctly. And you'll have something like the Quality Improvement Network research program. Okay. Now, education of the masses, the people, everybody, the public, the patient, everybody else. Well, you can implement a national media campaign, and it's what they do. Notice, I highlighted it in some spots. Shall is the word they use in legal terms. They don't use the word will usually. It's shall. Shall or may. Shall means you have to do it. So when it says the secretary shall do it, the bill was written and says the secretary has to do it. She has plenty of power, Kathleen Sebelius, the Secretary of Health and Human Services, to do literally hundreds, if not more than 1,000 things on her own decision. But she has to do something. Information may be targeted to specific groups based on peer-reviewed social research. You know, they don't miss a beat. It's on Facebook, Twitter. And let me interject here. I just heard this, and most of you know this, that Google sells ads, right? Paid for ads. What is the #1 ad if you Google Obamacare and abortion? Or Obamacare and Medicare? Obamacare and Medicaid? Obamacare and best practices? Every one of those combinations will come up #1 to a government website. Check it out. At your taxpayer expense to make sure you get the right message.
Big Brother knows best.
They do. Shall establish publicly available guidelines for health assessment and standards for interactive, telephonic, or web-based programs. You know, like I said, they don't miss a beat. If you get information on the telephone, if you get it on the web, not only will their information be there, it's one level deeper. They're going to tell you the standards for interactive telephonic programs, the standards for you creating a website to put it out there so it's accurate. I mean, hell, they can't let bad health information out. You have to go by their standards with your own information, too. Secretary shall award grants or contracts to develop patient decision aids, which will provide present, up-to-date clinical evidence for patients from a variety of cultural backgrounds. I highlighted some stuff because that's the word that you want to key on, patient decision aids. If you don't know what it is, I'll get into it. States that are awarded a grant or program shall conduct outreach and education if they get any Medicaid money. Well, one of the Medicaid money they get from the government, federal government, to the states to incorporate programs in the state Medicaid program is a behavioral modification program. guess whose behavior they're talking about.
Yours, I'm sure it would be mine.
Yeah, indeed. It'll implement a plan for the dissemination of information for all healthcare providers. And now, for medical providers more specifically, I have to tell you that some of this can seem like it may not affect you, but what goes on with the doctors and the government is much more important to you as a patient than what the government does directly to you as a patient, because they have trouble doing that because you hear about it. They have a hook in the doctors. What is that? They just say that if you don't do it the way we say, we won't pay you. Medicare wages will disincentivize. We'll pay you 2% less. We won't let you sign up. They can actually kick you out for various reasons, and they can control the number of providers. So if they, for whatever reason, have something unpopular and they don't want more doctors or whatever, they just say, no more doctors for now. So the United States Preventive Services Task Force is making recommendations to doctors, and it's always done that. I looked those up. Although in my later years of practice, I went to places like the American Association of Clinical Endocrinologists. I didn't even go to the ADA, because you'll know, for example, with the AMA, AARP, and believe it or not, the American Academy of Family Practice, which I quit, is overrun with far left people running the show. And bring that up if you want more at the end about that. It's fascinating. There's going to be shared decision-making resource centers to make sure that doctors know how to use decision support things, decision support aids, that are, of course, put out by the government and pop up in their electronic health records. More on the electronic health records later. I talked about that in the whole talk, and it's kind of the linchpin of the doctor education. You'll assist providers with implementation of effective use of decision aids and disseminate best practices, and you'll disseminate research on patient decision aids. After you get them, you research how they work, and then you actually know better how to sell the research aid, the decision aids, to the doctors so they use them to collect the information on the patients that you want. I'll have to take questions later, but I will, because actually I'm running later than I thought. I'll speed up. But definitely, yeah. Office of Communication and Knowledge Transfer. You know, these things I highlighted in orange like that are exactly out of the bill. In fact, a lot of this is out of the bill, but I've cut out the crap so you can understand it. But I put it in there so you know. This isn't me making this up. I want to get the flavor of what they want to accomplish with the bill. And although it can be boring or overwhelming or same old slide, the fact of the matter is you can see the pattern if you see enough of the picture. Yes, there's an Office of Communication, Knowledge, and Transfer that will disseminate research findings. Again, tell me if they missed a base. If they got all the ones I can think of, to physicians, to patients, to the vendors of health information technology, that is the ones that put in the guidelines and sell to the doctors, and the doctors have to buy certified electronic health records. I don't know how many of you knew that. The government certifies them to put in what they want, and you have to buy certified ones if you want to be paid by any federal program. Medicare, Medicaid, federally qualified health centers, CHIP, S-CHIP. If you want to be paid by a government-supported or even indirectly program, you have to use a certified electronic health record, certified by the government. And health information technology, professional associations like the American Academy of Family Practice, the AMA, the AARP. Do I need to name any other leftist organizations? And federal and private health plans. Federal and private health plans. Okay? They'll create information tools for the doctors. They'll develop public resource database, a publicly accessible resource database on pretty much any information they collect. I have a whole section on information collection. Education for the masses again. This is last slide for that. They shall make available aggregate reports with respect to physicians concerning utilization of care. Basically, they're going to tell you if your doctor is using a lot more care than the other doctors, okay? And the only reason they would want to tell you that is so you could make some kind of decision. And they could do it for good reason, or maybe they want you to make their decision. But they want you to be able to make a decision, so they're going to give you the information concerning utilization of care. And the performance information summarizing data that is provider specific. Well, it sounds good. I'd like to know, if my doctor's a schmuck or if he's a good guy. But, if you're going to have all that information, where are you going to get it? How are you going to get it? Who's going to get it? And are you going to have any say in what information goes in there? Or could it possibly be one-sided? Well, if this is a slide, here's how they'll obtain some of that information. On the bottom, it shows systems that collect, analyze, and aggregate data span an increasingly broad range of patient populations, providers, and geographic areas. In other words, electronic health records used by the doctor that he has to use if he wants to get paid if he's in any government-funded program will report back this information. You go, well, he wants me to pay attention. He said report back. That's right. I didn't say you reported as a physician. You have to make quality reports, but these electronic health records are not certified by the government unless the vendors have put in hardware that reports back to the government automatically. Now I'm getting into the realm of conspiracy, aren't I? No, I'm not at all. Not at all. If you have Adobe and it updates itself every week on your preferences, you don't have to tell it to go update Adobe or Microsoft Update. It just does it. This information that's collected in these electronic health records is going to go back to the government automatically. You know what else is going to go back automatically? And just luckily, it is. Because the doctors might not want to report it. And you need to know it. Can you imagine what that is? It's quality information on if the doctor is following the government guidelines. That goes back automatically to the government so that they know and they can let you know that that bad doctor is not following their guidelines. Do you wonder why doctors that know about this don't like this bill? Because I'll tell you, I'm out of medicine. I retired a couple of years ago. I saw this coming and I could not stand practicing anymore. Literally could not stand it. When I walked in and saw a patient, I forgot about everything. I could be in the worst mood. I talked to him. I thought of nothing else. It was like another world. The minute I walked out of that door, still in my office, I instantly got depressed with the running of the business and everything else about the business. And I am not kidding about that. You're not going to have doctors in 20 years for that reason and many others. Family primary care doctors. More stuff on how they obtain information. Promote systems to provide data, that's health information technology. And summary data for particular populations and providers. Again, bad enough that Dr. Berg feels a little put out that they're singling him out and the other doctors. But they're going to single out populations too. And you may be in a population that you don't want to be singled out. Here's something interesting, and I gave a talk and I mentioned about the Census Bureau. And I didn't fill out all my census information. I called and I wrote a letter, and I never got written back by the government. Told them why I wasn't going to do it. I said, you use all this information everywhere else, and you say on the Census Bureau website that you don't do that. Well, this bill says, these are the words out of the bill, that they will conduct, you'll get information from any federally conducted or supported healthcare or public health program. I had to leave it all in here because it's very inclusive. Activity or survey. So that includes current population surveys by the Bureau of Labor, American community surveys. 10% of the people get that a year. It's not the normal census, but it's from the Census Bureau. And they'll collect that information and report data on race, ethnicity, sex, primary language, and disability status. And you have to do that. You know, supposedly you have to fill out those Census Bureau population surveys too. I didn't even fill out all my regular ones. The very first question, if anyone wants to go over with me, was unconstitutional, basically, in that survey. And any other demographic data. Didn't I cover enough? Any other demographic data as deemed appropriate by the Secretary regarding health disparities. Well, if you do any research and you find out anything, I'm not talking about Hispanics getting worse care because doctors give worse care, even if that were true. I'm talking about if you notice any disparity in health. In other words, if Ashkenazi Jews have Tay-Sachs disease way more than everybody else, which they do, 10%. Otherwise, it's 1 out of 10,000 in non-Ashkenazi Jews. Well, now, that's a health disparity, and the Secretary has the right, in fact, this bill gave her the right to go out and get any demographic data that she wants based on that fact that you might be Jewish, for example. Okay? It's pretty amazing. Okay, and more about, I'm running a little long, more about obtaining information. They can get it from any place they want. I have more information later on the Medical Advisory Board. States must participate in the activities. If they get any money, they have to collect information at their expense, by the way, which is why I told Bob McDonald not to take some of that Medicaid money, because after the first year when you use it, the $25 million he took, you have to keep funding that forever on your own, the state. And again, if you get one of those state-awarded behavioral modification grants, you have to report back. And the report back is on anything the Secretary wants. Because you asked to it. You took the money and you said you would do it. Yep. Now, just so you don't feel left out, and I think this is probably where I'll leave it for this section of it, is a Medicaid beneficiary must complete a health risk assessment prior to receiving personalized prevention health plan services. You can do that, or when you get Medicare age, you can have your annual physical, the one-time annual physical. Or you can get this. This, for other reasons, is incentivized more, and it's more complete. Most people would take this. To realize you must complete the health risk assessment, and they get to ask anything on it that they want. I think I have a slide showing the wording of that. So if you fill that out, all your information is fair game. All the information they ask of you. So, you know, if you complain that the doctors give too much information, or anybody else, make sure you look in the mirror, because actually patients are given a heck of a lot of their information out when they shouldn't be. I think that's probably it, except the, oh yeah, as far as patients, they're going to check on your medication adherence, okay? And they're going to check on other demographic and clinical characteristics and health service use of your patient. But the problem is, not going into any more information collection, is how do they know that? And there's various reasons. Okay, tell you what, I want to give you a break because it's sort of boring just seeing this, because this is the way the bill is. But I'll tell you.
It's not boring. No, I'm very interested.
But I tell you, what I am writing there is just cutting out the junk and making so you can read it. This slide, if you had to find that and figure it out, that information on that